Hey, welcome back to the Runner Zone podcast. Chris, how are you, man?
I'm doing well. It's just sort of one of those days, man. You know, I was telling you just before we hopped on this call that just some chaos with a friend of Mimi's whose son was in a car accident, and this precious life, man. How are you doing?
Yeah, I'm good, man. Yeah, better than you all. Yeah, that's scary stuff, man. When those things pop up, you're not prepared for them.
No, and all you can do is just support the people who are going through with it, and hope that the person who's involved just rounds a corner. But
yeah,
it's just crazy, man, how life can just change in the snap of a finger.
Yep.
And it's just a reminder to grab the people that you love and remind them that you love them, right?
Yeah.
So, yeah.
Yeah, absolutely. Let's talk about the knee.
Let's do it.
So we're going to break this into two parts. We're going to specifically talk about intra-articular knee pathology. And we figured we'll kind of split this up into sections. So today we'll cover some of the basics, and then we'll kind of round out the whole thing in a second part. But today we're gonna be talking just about some of the basics behind that. So, the knee is obviously pretty important for running. It tends to be one of the most highly cited things with injuries. When you hear intra-articular knee pathology, what comes to mind for you? What are you thinking of?
When I hear intra-articular knee pathology, I tend to think with runners, depending on their age. I mean, I'm seeing a lot of master's level runners. So if I evaluate them and they present with a knee effusion in particular, I'm thinking something's probably going on with the medial meniscus. Granted, people can get, articular cartilage lesions. I had an OCD lesion when I was younger, when I was maybe 13, 14, which is osteochondritis dissecans. It tends to hit the medial femoral condyle, though it can hit other regions of the knee. So, but I generally tend to think of meniscal pathology in these folks, unless there is some sort of trauma, at which point we're going to be putting on probably a little bit of a different thinking cap and really zooming in on the ligamentous structures. How about you?
Yeah. Same thing. So I have a model in front of me. So if anybody's watching on YouTube, so the blue stuff that you see, the stuff that's in between these two bones, that's what Chris is talking about. So your menisci, and like you said, if we're talking about running, that tends to be the thing that people have a hard time with. You don't see as many ligament tears, ACL tears, PCL tears, those kind of things as you do with football, basketball players. But unless someone falls or, their foot gets stuck into something. But most of the time it's some kind of meniscal pathology. And it seems like there's a bunch of different ways that people go to manage that. And some good, some that maybe we could do a better job with. And like you said, I tend to see this a lot in older runners, really like maybe 30s starting off, but definitely when you start to get into like 40s, 50s, where you are seeing more of this kind of gradual onset of swelling and knee pain, especially on the inside of someone's knee, that tends to be worse with, running, squatting, other activities that load your knee. And so then, we got to put our heads together, figure out what's the best way to help you get back to the specific demands of running, which are very different than if you play tennis or if you play basketball or you do something else like that. Running is very, very different. When you think about the knee, what do you feel like the requirements are for distance running? What are you looking for? How are you analyzing that?
Yeah. And before I answer that, I think something that's really helpful for listeners is to understand that you and I did not start off seeing runners. I mean, we were in the trenches with a lot of people who were dealing with ligamentous pathology, were dealing with articular cartilage lesions. And I think that when you are working with people who suffer all sorts of different types of knee injuries, including people who go on to need knee replacements, that you really learn to evaluate the knee from a comprehensive standpoint. So over time, we obviously have sort of niched down and working with runners. So, the problems are very predictable that we deal with, and they're not nearly as involved, unless, like we said, someone has trauma. So I think, when I'm working with a runner who comes in with knee pain, I'm like, oh, we're going to be able to help you. We're going to get you dialed in and get you on the other side of this. In terms of just requirements of the knee, when we teach this stuff, we always emphasize the point that running is a mid-range activity. If you look at like the classic article, The Biomechanics of Running from Tom Novacek, I think that was 1998, in Gait and Posture, he basically says, look, the knee cycles through roughly 20 to 45 degrees of knee flexion or bend when you're in stance. And then you have to look at
one second for someone that's not maybe a rehab pro. What does that look like when you say let's say 45 degrees of knee flexion at max? How much range are we talking about?
It's like basically probably going down a step, which is why we put such emphasis on the lateral step down when we're assessing runners, because we're essentially trying to cycle them through that range that they're going to encounter during the running gait. Now, if someone, is running a little bit more brisk, they'll actually probably get into less knee flexion, right? So the longer you're in contact with the ground, you'll probably start to broach that 40 to 45 degrees. And then with open chain, it's really a function of speed. One of the things that we always remind people of is our bodies are not dumb. The faster you run, the more your heel is going to approach your bottom, and you're just basically, that's not something we cue either, right? Anytime you get someone to adopt, some sort of strategy that's non-native, it's probably going to occur at a greater metabolic cost. And Follin and colleagues talked about this in one of their classic manuscripts about, common denominators of high-level runners. So, when you're working with a runner, just understand knee range of motion requirements are minimal. The quadriceps function is very important. And I think from there, obviously looking at proximal and distal factors too.
Mm-hmm. And to touch on that, the heel recovery that you had mentioned. So when your leg is off of the ground, moving in the air, that does seem like something that used to be cued a lot. I know that chi running and pose running and all those form schools, I think, tended to coach those types of things. I don't know if that's maybe as common. I don't see that as much anymore. Maybe it is, and I just don't notice it. But yeah, that is, and I think that's pretty true on a lot with running form and running gait is the body's going to figure it out. Sometimes we might need a little nudge or a little adjustment based off of something that hurts. We'll get into that specifically with knee pain in the second part of this. But I do think that most of the time, if you're thinking too much about running, it's probably not going to be helpful. The body's pretty smart at getting from point A to point B. I mean, and I think that it's really important to start with just that simple analysis of what does this structure have to do with running, because that's how, if we're dealing with pain, you want to approach looking at what are the things we need to take away, what are the things that we might need to add, what's the best way to help this specific thing, even before we get into, it's your meniscus versus your cartilage versus a ligament, and just say the knee is not at 100%. So what can we do to help that be in the best position for success?
Yeah. And I also think that when you're rehabbing a runner who presents with knee complaints, that the running is actually less of a concern to me. It's more like, what are the demands of their life? Because I think you have to appreciate, as much as we say, oh, we're not doing a lot of like full range activities from a rehab standpoint. Well, in certain instances, you need to, because life is going to take you into those positions. So, it's like we both have kids. Sometimes you're going to be on the ground playing with them. You may have to go into a deep squat to pick them up. So, when you're rehabbing a runner, look at them through the lens of what are the performance demands of running, but also what are the performance demands of their life. I mean, you always talk about the brewer that you've worked with. I mean,
Mm-hmm.
she's picking up those heavy satchels of hops that are like 40, 50 pounds. Like, you need to understand what she's going through on a day-to-day basis, on top of, what are the considerations related to her running.
Yeah, and we talked about that with regards to the hip in the last episode too. It's the same thing with the knee, where if someone comes in and they have knee pain, you want to make sure that if running is painful, is it truly from running? Is it things outside of running? Is it both? Because you need to make sure that your plan is going to encompass all of that stuff. So whether it's kids, whether it's a gym routine, maybe it's someone that, they love to do lunges, or they love to do deep squats, and the only thing that they probably need is to just say, why don't you stick to half squats till your knee feels better? Or let's give you a different variation of something if that's what's giving you pushback. So you want to analyze the running, but you also want to make sure that the things outside of running aren't impacting this. And oftentimes they can, whether it's a routine that they do, or their job, or their home life, or whatever it is.
So I know we're sort of sticking with the theme of like intra-articular pathology, but what are the most common presentations when you have a runner show up to your facility with knee pain? What are the most common things that you see?
Yeah, and I think it'd be helpful to talk about what the session looks like and then what they tell you. So normally if someone comes in with knee pain, they might have some low-grade swelling that you mentioned. If there hasn't been a trauma, if there's been a trauma, they've twisted their knee, they were in a car wreck, they, felt something pop, they might have a little bit more, and that would be a different situation. But if someone comes in and they kind of said, my knee has been gradually getting worse over the last weeks or months, they're often going to say it's, it might feel a little stiff. I get a little tender on the inside of my knee. At least that's the most common spot I see. There's a little bit of swelling that, you and I would assess with the swelling test that you've put videos out on before. We'll put one of those in the show notes so people can see. And then they're going to say, it hurts when I go downstairs. It hurts when I squat. And then when we look at running, a lot of times they'll say, hurts a little bit more when I run slower. I've had this specifically with people that'll get knee pain when they run with, training partners that are slower than them. So I see this a lot with high school kids, where maybe you have a high school kid that is one of the faster people on the team, but they run their slower stuff with their friends that maybe aren't as fast. And so their pace that they're covering is way slower than maybe they would normally do on their own. And they start to get some pushback. And we've seen that in the literature, where running at slower speeds is going to increase the cumulative load at the knee. So a lot of times people will say it hurts worse when I run a little slower. It feels better when I run a little faster. And then they'll normally say it hurts when I go downhill, when I run downhill. And sometimes it'll act up with them, later on after running too. So it might flare up a little bit, but that tends to be the most typical presentation, or the most typical things that someone will say when they come in with a complaint of knee pain.
Mm-hmm. Yeah. And I mean, for folks who, who may not see as many runners as we do, I mean, generally they're going to come in either complaining of patellofemoral pain. Maybe they have some medial joint line pain that may be associated with meniscal pathology. They could have ITB pain. They could have a patellar tendinopathy. I've seen a couple medial tibial bone stress injuries, but I would say those are very rare. And there's a couple. There's one case report where it was a trail runner who probably really spiked their training loads, but and
they tend to be more distal too. So if we think about, so I have a knee model again. If anybody's watching on YouTube, if this is your patella, a lot of times if people have patellofemoral pain syndrome, it'll hurt around their kneecap. So right around the front, maybe on the inside of their kneecap a little bit. If people are dealing with medial compartment osteoarthritis or a meniscal tear, they'll say it hurts more on the inside. IT bands more on the outside of the knee. And then like Chris had mentioned, I've seen a few people that have had tibial stress fractures that are up near the medial lateral aspect of the proximal tibia, so the proximal part of your shin bone, but it won't be up here along the joint line. So it'll be a little different location. And I've seen that in a few kids too, mostly high school kids for whatever reason, that come in with that diagnosis. And I've actually seen a few that have had that bilaterally. So yeah, I think that, location of those symptoms does play a big role in trying to figure out what's the tissue that's involved. It might not completely overhaul someone's rehab program if they have IT band syndrome versus patellofemoral syndrome. But I do think you want to have a working diagnosis and not just say, well, it's just knee pain. I think that we don't have to be specific, but we should try to isolate a tissue if we can.
And I think this is a good opportunity to just go over some higher level clinical pearls. So like if we stick with bone stress injuries around that condylar region, generally you will not see a knee effusion with these people. Mm-hmm. Their range of motion is not limited. And I think that this is where the clinical reasoning is really important. So, just some other things. Patellofemoral pain, that is generally a diagnosis of exclusion. Mm-hmm. These are folks who we generally don't tend to see a loss of knee flexion. They generally don't tend to have a knee effusion. With ITB pain, we don't see ITB pain in basically competitive, experienced runners. This is someone that you tend to see that in people who may be a little bit more inexperienced with runners, or who may fall under that recreational distance runner category, which is not a bad thing. It's most of us, right? Sure. And I think with meniscal pathology, it's like you need to understand the implications of a knee effusion. If someone has swelling in the joint, that could be stemming from an arthritic process. It could be meniscal pathology, depending on the age and demographic. Those people very often will have a loss of end range knee flexion. They won't be able to get into deep squats. So there's just a lot of things that will cause your antennae to go up based on what someone reports, as well as their presentation demographic.
I think that when they say those things too, so when they say I can't get into a deep squat, they'll also a good follow up is where do you feel it? Because sometimes people will say, if I squat as low as I can go and I feel it in my kneecap, I feel it in the front of my knee, versus I feel it on the inside of my knee. I think that plays a factor in this too, and trying to figure out what they might be dealing with. So when someone says my knee hurts, where does it hurt and with what activities? And those demographics that you mentioned. So you're probably not going to see osteoarthritis in younger runners. But if you're dealing with someone that's 40, 50 years old, you might be seeing some symptomatic osteoarthritis if they're reporting knee pain and some swelling and a loss of terminal knee extension and loss of knee flexion, the things that you just highlighted. So you're always trying to put all this together and say, based off of how this person presents, their demographics, their training history, this is what I think they're dealing with. Because we can't go just by an image, like you mentioned. You can't just get an X-ray and an MRI and say you have patellofemoral pain syndrome. Yeah,
I mean, I think I think back to maybe about 14 to 16 months ago, I was doing a bunch of videos for a project, and ton of plyos during the final weeks of the video shoot, and then all of a sudden I started developing a knee effusion on my right knee. And I got to a point where for the first time in 15 years, I just had to shut running down for about 6 to 8 weeks. I tried a couple times and I just pulled the plug. And what was interesting, I never got imaging, and I was like, oh shit, wonder what's going on. My knee was a hot mess. I was carrying like a 2+ knee effusion, which is a pretty significant amount. I couldn't bend past maybe 100 degrees. So, if you're thinking about this from a clinical standpoint, you're like, okay, well, Chris did have this OCD lesion from when he was younger. Maybe there is a degenerative meniscal tear, or maybe he just flared up, an arthritic process just because he spiked his training, through the plyos. And the reason all this is important is because it's going to dictate how you approach managing that individual. So, that was atypical though.
Yeah, but let's go to you in that moment. We're going to touch on surgical options versus conservative options with intra-articular knee pain or intra-articular knee pathology. So when you had that moment, the studies that have looked at conservative versus surgical, outcomes. Mm-hmm. Were you ever at the point where you're like, maybe I need surgery on this? Or did that never enter your mind?
Yeah, dude. No, 100%.
Yeah.
This is a funny thing. We, as clinicians, we still have these maladaptive thoughts sometimes, and
Yeah.
I'm just like, oh man, I'm like, is this I told my wife, Mimi, I said, is this the beginning? Like,
Yeah.
am I going
knee
to
replacement.
have to?
I'm destined to a knee replacement. Yep.
Yeah, because I was told by a couple of physicians when I was younger that I would need a knee replacement, if not both knees replaced, by the time I was in like my mid to late 30s. So I'm thinking, oh man, I had this OCD lesion. I wonder if I just sensitize the shit out of it, or maybe I have I have medial joint knee-OA, or medial compartment arthritis. So I'm like, oh, do I need to go in and get an MR? Am I going to need to have my knee scoped? Is this the beginning of the end of my running? And then fast forward a year later, I was able to, I'm back training full force, and it's just a reminder, like, just stay patient. You will get on the other side of this stuff if you create the environment, stay on top of wellness factors, and let the body do its thing, because that homeostasis got disrupted in my knee. And I think that it just immediately made me think of that article by Scott Dye, 2005, such a seminal paper talking about, a lot of this was related to patellofemoral pain, but, always thinking like, how did homeostasis get disrupted in this person's knee? Because how do we create the right environment for them to get on the other side of it? But yeah.
And, sometimes it can be so hard in the moment if you're the person, or even if you're the provider working with someone, to say, this will just take time. Like, time is going to be an important part of this, and complete resolution of what you're feeling might not be needed or likely, so, and that's one of the things that I think is important with this specific diagnosis is, if you have, say you have osteoarthritis in your knee, and it's, symptomatic osteoarthritis, or you have some other kind of pathology, a successful outcome conservatively with that could be, I train on a consistent basis with a 1+ knee effusion and low grade symptoms. But I'm training and I'm doing the things that I enjoy, and I'm still able to push myself. But, and some runs I have that go well, and sometimes it's a little bit more sore, so I have to modify things. I have to take an extra day off. I have to be careful about my long run. I have to be careful about downhill sometimes. I think that is also a successful outcome.
100%.
It doesn't have to be, I have no pain. And that's the only thing that matters. And I deal with that with a lot of older runners, like you'd mentioned, where you don't want to put a limit on their abilities, but you also want to say, like, it's okay for you to be running right now based off of how you're presenting. Now, if it's completely, you've lost tons of range of motion and the strength's not there, and there's other things, running might not be appropriate yet, but once you're getting back to it, continuing to train with low level symptoms, I think, is often okay. You're not doing yourself a disservice. And I think that sometimes getting you back to activity, a thing that you enjoy, that's important to you, with low level pain, is better than trying to go for no pain at all.
And I think it's important to teach people how to self-monitor their knee effusion. So, when I was at Delaware, you just had to know how to assess for a knee effusion, because they were publishing on a lot of this stuff. If you want to read more, Lynn Sturgill, Lynn Snyder-Mackler, and Dr. Axe did a paper and just showed it. Assessing a knee effusion is very reliable. So, and that's something that I've changed my thoughts on a lot, having gone through this, where I'm okay if someone's running with a tracer 1+ knee effusion, so long as it doesn't get worse. And this is why it's important to teach someone how to self-assess, because if they start a run and they're at maybe a tracer 1+ knee effusion, and they start to feel a sense of fullness or bogginess in their knee, as they start to get further into that run, well, that's probably not something they should continue to push through. Now, in a lot of instances, people will actually have the opposite happen, where they start a run with a 1+ knee effusion, and by the end of the run, there's no knee effusion. Not to say it may not return later, return to baseline, but that's a situation where I'm like, let's keep you going. Let's have you run on non-consecutive days. But I used to always say, oh, you have a knee effusion, we need to shut you down. And you and I both know, man, like how often do people come in where they don't have a knee complaint and you're just examining that extremity and they have a 1, if not a 2+ knee effusion, and they're out doing whatever the hell they want.
Yeah,
you know?
Or they have pain at end range of extension or flexion. It's the same thing in the hip. How many people that if you assess their hip, they don't have hip pain, but if you take them into like a Scour's position or internal rotation or flexion, they say, ooh, that doesn't feel comfortable, or I get a lot of pinching there. I think that all that stuff is, it's normal. To me, it's like palpating. Like if you were to take a runner and you were to palpate most of the muscles and tendons of their lower leg, especially from the knee down, they'll probably be sore and potentially painful because they have to deal with training and life. And, it's normal. It doesn't mean it's a problem. A lot of people have that stuff and they don't have any issues. That's why the clinical exam matters and what you do, but it doesn't matter if it doesn't have the context of the person's situation. And we used to get into a big rabbit hole about telling people they have all these dysfunctions and things like that. And our field probably still does that a lot too. When really they're like, I'm good. Like I don't have pain and I can do all the stuff I want to do. But when we break into an examination, we can tell you all the bad stuff, all the terrible things you've got going on,
And something we should have said from the outset too, is that, when you are examining someone's knee, I mean, the first thing I think of the last 3 people that I saw this week presenting with knee complaints, the first thing I do is make sure that they have full knee extension. So I'm assessing a knee effusion and I'm looking to see if they have full knee extension, because already that starts to basically have me barking up one of a few different trees. And, in all of these cases, they did have full knee extension. So you're thinking, okay, well, there's probably no mechanical block to the joint that you may see if someone had a traumatic knee injury where they twisted their knee and likely sustained a meniscal tear, perhaps a bucket handle meniscal tear. But I've only seen maybe 3 of those in my career where someone's come in through direct access and they're sort of limping, and one person got tripped up on a route when they were running. And they had bucket handle meniscal tears, and I sent them off and they ended up undergoing a knee scope like within that week. And I think that was the right decision. I haven't seen people where those spontaneously resolve. I know there are some like manual therapists that have certain techniques. I've never seen it work. I don't know.
You
about
can't reposition a meniscus. I can reposition a meniscus, Chris. Come on.
I can't.
That's an advanced technique. You just haven't learned it yet.
Yeah, that's fun.
Yeah. Sometimes you need surgery. And I think that certainly with distance runners, with these kind of things, with insidious complaints, you want to make sure you exhaust lots of things before you get to the point of having anesthesia and a knife. But there are times when it's necessary. Just like sometimes you can go through a good rehab process and you do all the right stuff and you end up having a scope and you have a good outcome on the other end of it. I wouldn't lead with that. But you might need it at some point. So that's okay. Just make sure you are informed about the pros and cons of all the different things you can do. And in my opinion, you exhaust all the conservative options and then you go down the line. I think it's the same thing with injectables. We haven't talked a ton. We had Kintaro and Nishi talk about injections on one of the most popular podcasts that we have. I'll put that in the show notes too. But sometimes people get stuff shot in their knee and they feel better. Now, why that happens, whether it's cortisone or PRP or stem cells, I don't know. But sometimes they do that and they feel better. Especially with these pathologies. That tends to be another go-to with intra-articular knee pain, is some kind of injectable.
And I think with all of these procedures, if you do end up electing to have surgery for whatever reason, especially if you're dealing with, say, a degenerative meniscal tear, what happens in rehab is there's really nothing you can violate at that point. So a lot of clinicians who may be a little bit more green will get carried away and plug you back into activity. I mean, if I had my knee scoped and they did a meniscectomy, I would be on the bike for probably at least the next 6 to 8 weeks. I would not be doing anything running related, because I've seen people who are doing well and they introduce running prematurely before they regain quad function, and they end up having a litany of issues down the line. And I've just never seen that go over well. So, and same thing with injections. Like, I see too many people that will opt for a corticosteroid injection, which, like, I'll never let anyone shoot that shit in my knee, man. It happened twice, and it was like I had a flare response. But just let things chill. You know, my policy, if someone comes in and they had a corticosteroid injection in a weight-bearing joint, minimum 4 weeks, no running. You know, and if you do, you're on your own, because I'm not going to get dragged into that mess. You know, and I know the knee's feeling fine, but I don't know what the therapeutic, if you still require a therapeutic use exemption, if you have a corticosteroid, or how that works. But yeah, you're playing with fire.
Yeah, I think that happens a lot. Meniscectomies, especially if they're small ones, like if the surgical procedure wasn't a large tear that they cut out, that a lot of times people will plug it back in too quick without the kind of graded approach that you and I both think are probably more appropriate. And in the second episode, we'll talk a lot about exercise prescription. But I think that's another error that people happen. It's you have the surgery and then there's no kind of loading program that really reflects what you have to do, which for running, like you mentioned before, you need to be able to go through 45 degrees of knee flexion on one leg, probably with some extra weight, some extra load, and challenge other stuff, and have a plan that reflects what you have to do as a runner. I think that it's too easy to say, have the surgery, have the injection, just chill for a week, ride a bike, and then plug back into running. And I think that sometimes people don't realize how much capacity you do really lose if you have even a couple weeks of not doing something. It's not to say you're going to be out indefinitely, but you do probably need to modify training more than you think you should. And so being with a rehab pro that I think understands the demands of running and what that looks like, I think is really important, because it can be so easy just to plug back in.
Yeah. And I think that, you know, when you have, when you undergo a knee scope, I mean, it is essentially trauma to the knee, and it's not uncommon to develop a knee effusion and your quad can shut down where you get quad inhibition. So I think, you know, we don't give enough attention to quadriceps strength and function in runners. People are like, oh, you're a quad dominant runner. And I think people shy away from loading the knee up through squats, you know, knee extensions, things like that, which are really important to restore quad function. And this is a case, I don't do a lot of isolated strength testing with the dynamometer to the extent I have in the past with other populations presenting with knee pain. But I do think that I bought this Mark 10 dynamometer at the recommendation of Scott Morrison, and I have that specifically if I'm working with post-op patients who are looking to get back to running, whether that's following an ACL reconstruction, maybe they're just a running athlete, or if they have a meniscectomy, because they need to realize that their quad's not functioning to the extent it needs to be. And then plug that in with the Dorn study that shows that your quad's working with having to contend with at least 4 times body weight.
Well, that's the, you know, you and I both worked with some pretty high level runners. And when you look at some of the, you know, the pros and the higher level people, like, they have really strong quads.
They do. Yeah.
Maybe their balance and their control, maybe calf strength, it could do some improvements, but very rarely do I see someone that their limiting factor is they can't bend their knee with weight.
Yeah.
You know, in a non-painful situation, if pain, you know, when pain enters the equation, it's a little different. But if you're, you know, most runners have pretty strong quads, and that's not a bad thing. You know, it's like looking at a swimmer and say they have strong lats. You know, like, they need to have strong lats.
100%. So when you're examining someone on the table that presents with knee pain, what are the key things that you're assessing?
So I want to make sure it's the knee first. So I'm going to take them through a standing evaluation and looking at lumbar movements, flexion, extension, all those kind of things. Screen for, walking on their heels, walking on their toes, kind of going through a neurological exam. But then I want to take their hip through the ranges of motion we talked about in the last episode. Flexion, internal and external rotation, do a Scour's test, do a Faber's test on the hip, because the hip can refer down to the knee. That's not uncommon. And then when we're looking specifically at the knee, I'll take them through flexion with overpressure, extension with overpressure at end range. I'll do some palpation. So I'll palpate their medial and lateral joint lines. I'll palpate the patella tendon, palpate their quad tendon. If, I don't see a lot of runners with quad tendonitis, but if that's what they're complaining of, and then take them through some rotation. So some tibial internal and external rotation, take them through a McMurray's, which is a test you can look at meniscal pathology. I'm not really ever concerned about stability in their knee. So you could do a varus and a valgus test, do a Lachman's, look at the ligamentous structures, but and I'll still do those mostly because I feel like I need to keep that skill set. So I try to do those on every leg that I see. But the big things that I'm looking at is swelling and how they respond with flexion and extension, and making sure that their hip doesn't reproduce their knee pain when they're on the table.
Yeah, and I think that's really important because, if someone has a history of slipped cap femoral epiphysis, if they have leg calf perthes, if they have something, maybe they have an advanced arthritic process at the hip, all these things can refer to the knee and the medial knee. Even people who have, femoral shaft bone stress injuries, you would want to look at a fulcrum test just to make sure, again, that, as we talked about in the hip episode, that we're dealing with, a knee problem or a hip problem versus something else.
Mm-hmm. And you would also want to look at ankle mobility. So you talked about the table test in the last episode, but you would want to make sure that they have adequate dorsiflexion range of motion, or that at least that's symmetrical to their unaffected side. Some people have stiff ankles and it's not necessarily a problem, but, Peter Malieris's work with volleyball players found that these volleyball players that had knee pain, they had a little less ankle dorsiflexion. I think you and I see that in practice, where having some stiffness in your ankle could certainly affect that. Sometimes that's structural and normal, and sometimes it's something where you had, you spent time in a boot, or you had an old, you've had chronic ankle sprains or something along those lines, and some more range of motion could be helpful. So I would want to look at that too. There's this old adage, and it still goes around now, where the hip and the ankle are for mobility and the knee is for stability. I think that maybe that idea has some truth, but also I think it's really simplistic. But I do think it's important for you to check the stuff that's around the knee to make sure that it's not really the thing that's causing it, or a factor in why someone is developing knee pain. Yeah.
And we'll also have a lot of people that will report sort of like fullness or tightness in the popliteal fossa, which, again, when we hear that, it's sort of pathognomonic for a degenerative meniscal tear, medial meniscal tear, because those people always want to stretch their calves, which may not be a bad thing, but most people don't have the fact that that's probably a meniscal tear that's causing that swelling to occur, for them to develop a Baker cyst. So, and
they normally don't like anything with knee extension. So even like calf raises, if their knee is extended. But
you would also you also would expect to see that person carrying a knee effusion, loss of end range knee flexion. This thing, it has to fit the clinical picture, right? Mm-hmm. So, I mean, there always needs to be a series of checks and balances when you're examining someone, so your working hypothesis is accurate.
Yeah, absolutely.
Anything else that we're missing?
I think that's good for part one, because part two, we're going to talk about exercise prescription. We're going to talk about adjustments in exercise prescription, running form, shoes. We got a lot to cover in the next episode, and I don't think people want to hear us talk for 3 hours at a time, just spaced out over multiple episodes.
And there are two very important papers for anyone who is working with runners, people presenting with knee pain, which is going to be the vast majority of clinicians, from Scott Dye. And the one is, from 1998, conscious neurosensory mapping of the internal structures of the knee, which is critical because, the main takeaway from that is the retropatellar surface is aneural. Like, basically with that study, they had there are three people on the paper, but one of the surgeons, without anesthesia outside of just like a local anesthesia, underwent a knee scope from his partner, and they were basically probing,
Brutal,
all
man.
these different structures around the knee to sort of say like, okay, what's generating nociception? And it was, I think that they highlighted, it was like, the anterior synovial lining, the fat pad, and the knee capsule just like were painful as hell when they probe those with a blunt instrument. Because I think a lot of the times, people are like, oh, you have, chondromalacia patella, which is like the softening of the articular cartilage on the undersurface of the kneecap. Yeah, you can go ahead and show people.
Yeah, if you're watching on YouTube, so that's your patella. That's the back. That would be the backside of your patella. So yeah, if this is showing that there's some degenerative changes there, when Chris mentions chondromalacia patella, that's what they're talking about, is the backside of the kneecap.
Yeah, and that's generally, like, I have grade 3 or 4 chondromalacia patella, and I had that based on an MR when I was like 20, 21 years old. It's been a non-issue, and that sort of brings me to that second paper, which was, I mentioned earlier in the podcast, 2005. That Scott Dye wrote about, like, the tissue homeostasis perspective, because I think that concept is really important. He gets into this like envelope of function, homeostasis versus supraphysiologic loads. It's just a really nice way to conceptualize if someone comes in, especially if they're dealing with insidious onset symptoms, what disrupted the homeostasis in the knee. So when I was explaining my knee situation, it was probably all the plyometrics. I was getting into some like ass to grass squats. That's probably what did it, because I didn't necessarily modify my training to the extent I should have, because I'm in denial about the fact that I'm 44 and I can't jump and spring the way I did when I was 20, 25. But just asking the patient, hey, what do you think causes homeostasis? Or what do you think disrupted your knee, and let them weigh in, because they're going to know probably better than anyone.
Unless they're a high school kid, and then they might look at you like, what are you talking about, dude? My knee hurts. Just.
Yeah, exactly. Yeah. Put little stock in what high school kids say.
Yeah. It's a little different, situation.
Make sure you give them some food too when they're there.
Yeah. That is my favorite question to ask high school kids. I ask every time I see a high school kid, a client or a patient, I ask them what they had for lunch, or dinner, whatever's around. Just to see what they say. So we'll talk about a lot of stuff in the second part of the episode. And then all the studies that Chris and I have talked about, those are all in the show notes. So definitely click on them and check them out. And then we also have a video on kind of the orthopedic examination that we tend to put people through that people have found pretty helpful. So that'll be in the show notes too, if you want to learn more about the tests and stuff that Chris and I are talking about.
Well, this is hopefully this helps a lot of people. We love talking about this stuff, and if you have any questions, feel free to reach out to us, and then we'll get after part 2 in a week or two.
Sounds good, Chris. I hope you have a good rest of your day, man.
For the weekend. What do you have on
So I coach my first grade son's basketball team with another dad, and so this is the Destroyers' last game of the season. So
that's a great yeah.
Yeah, the kids chose the Destroyers. There was a second choice, but I don't remember what the other one was. So we have our last game this weekend. That's tomorrow morning. And other than that, I don't know what else we got going on. We'll find out, figure it out. I don't know. I'm going to go for a run at some point.
Isn't it funny how young boys just like gravitate towards violence? Like
all the time, man. That's my house all the time. Yeah. I have two boys, and all they do is punch each other or put holes in the wall. We have a counter in we have like a little island in our kitchen, and our 4-year-old, he's like sitting on it last night, and he just jumps off of it. It's like, I don't know, 3.5 feet off the ground. He's fine because his bones are soft.
He's like, bone health, Dad. Stop bothering.
I know, but like, I know, yeah. And then, well, you had mentioned like functional activities for, squatting down and picking up your kids. What it generally looks like for me is like, if I squat down, I'm going to get tackled by somebody. Like one of my kids is going to try to knock me over or jump on my back. So, you have to keep your head on a swivel and lower your expectations. It's like if they're conscious and there's not a lot of blood, we're probably good.
Yeah.
Probably good.
That makes sense. What are you reading right now?
I'm reading a book called Necessary Endings. One of my old coworkers recommended it to me. It's basically about like breaking up with things, like people and jobs and things like that. Yeah. And then I'm almost through the 5th book in the Red Rising series. It's my favorite fiction series. It's by a guy named Pierce Brown, and their newest, he has a new book coming out this summer. So I've been rereading all the 5 books in prep for the new one that comes out. So I just started that one, and it's good. And that's about it.
Yeah. Do you read multiple books? I am on a Stephen Pressfield kick. I have, I read his book, The War of Art, which is awesome for anyone. I mean, especially athletes, entrepreneurs. And I'm just about to finish up Turning Pro. And then I think that you recently read this Magic let me pull it up.
Oh, Big Magic?
Big Magic, yeah.
Yeah, Elizabeth Gilbert. That's a good one.
Yeah. And then after that, I'll start Rick Rubin's book.
Oh, nice. And yeah, that one will be good too.
One of our friends, Julie Hughes, sent me something that she just finished. I think she'll publish maybe in the next 4 to 6 weeks, maybe thereafter. But anyways,
cool.
She wanted me to read it and give it an editorial review, which I've never done before. I had to actually look up what an editorial review is. It sounded like a lot of work, and I'm like, oh,
no pressure, man.
I don't need anything else on my plate. But yeah, I said, of course I'll help her. So she's awesome.
Yeah, you had asked about multiple books. I try to do one fiction and one nonfiction at the same time.
That makes sense.
So I tend to read fiction at night, and I tend to read nonfiction in the morning or during the day. And then when my brain's kind of done, I try to go back to fiction. And sometimes fiction is like sci-fi, fantasy, that kind of stuff. Sometimes it's sports, either on an athlete autobiography or something like that. So I try to go back and forth, and then I'll read a lot more. So I do that, but I'll have more books probably in the summer too. So it kind of ebbs and flows, but I always try to keep something.
Yeah, we're both very busy right now, which is always a double-edged sword. But I agree. Sure. It's like my reading ebbs and flows too. So it seems like the way with most things in life. Training, business, books, all of it. Yeah. Yeah. Cool. All right. Well, you have a great weekend. Tell your family I said hi, and we'll be in touch. Actually, I'm going to see you. I'm going to see your punk ass in a few more hours. That's true. Yeah, that's true. Never mind. All right. I hope everybody else have a good weekend. Chris, I'll see you in like 45 minutes. Yeah. All right. Later. All right. We'll see you.